Welcome to the Jason Podcast. I'm Josie Briggs, Editor-in-Chief of the Journal of the American Society of Nephrology. We have a great issue for August, which should now be in your mailboxes, and I hope all our readers will find things there that fit their special interests. Today I thought I'd talk in some detail about two papers that deserve some special highlighting. Both are of clinical relevance to the practice of being a kidney doc. The first paper I'll tell you about is entitled Sodium Bicarbonate Treatment and Vascular Function in CKD, a randomized, double-blind, placebo-controlled trial. The lead author is Jessica Kendrick. Now, as our listeners know, lower serum bicarbonate levels, even within the normal laboratory range, are strongly associated with the increased risks of cardiovascular disease for patients with chronic kidney disease. Two important unsolved questions about this association. First of all, what is the mechanism? Is it a correlation since acidosis develops as CKD progresses, or is it truly a causative association? And if so, how does it affect vascular function? And big question number two, should we correct it? Guideline-based care calls for administering alkalizing treatment to patients with CKD whose bicarbonate is lower than 23. But there's no clear answer about the benefits of correcting acidosis for patients with CKD whose bicarbonate is in the normal range. This is a complex question and a controversial one. The observational data is pretty strong, but the interventional data we would like to have and sorely need is still very sparse. And the paper we're talking about is a useful contribution. We all know that cardiovascular events evolve over many years, coincident generally with the progression of CKD. Small interventional trials have suggested that alkali therapy may slow kidney disease progression. But the big prospective interventional trials with sodium bicarbonate are still lacking and will be hard to do. But these authors undertook an important intermediate step. They did a randomized trial in participants with CKD stages 3B to 4 and normal serum bicarbonate levels. They focused on short-term measures of vascular function. The intervention, administering sodium bicarbonate, did increase plasma bicarbonate levels. It also affected urinary citrate excretion and reduced urinary ammonium excretion, establishing that it actually reduced underlying acid retention. Nevertheless, it did not improve brachial artery flow mediated dilation, it did not reduce aortic pulse wave velocity, or reduce left ventricular mass compared with placebo. Now, these outcomes are not a substitute for CVD events, but they are good short-term measures. And they tell us that bicarbonate administration in the period of this trial did not produce measurable improvements in vascular endothelial function, didn't reduce arterial stiffness, or prevent LVH. So the authors conclude, and the editors were very comfortable with this conclusion, that the study findings do not support the use of sodium bicarbonate for vascular dysfunction in patients with CKD and normal serum bicarbonate levels. In an accompanying editorial, Don Wesson notes that other work has found that a diet high in base-producing fruits and vegetables in patients with CKD was associated with improved cardiovascular risk parameters. But we're going to have to wait to see whether such dietary treatment of acid stress or other interventions along the acid stress continuum will reduce cardiovascular events. An important an unsolved question, but a very reasonable step to an answer. Another paper I want to highlight today is entitled Outpatient Antibiotic Use is Not Associated with an Increased Risk of First-Time Symptomatic Kidney Stones. This paper is from a team at Mayo. The lead author is Sharat Thongprayon. As our listeners know, kidney stones are a common occurrence, and the question of what advice to give to a patient who has a stone is of great practical importance. Antibiotics modify the gut flora in ways that could potentially contribute to stone risk. And prior studies, observational studies, have reported an increased risk of kidney stones after antibiotic use. So this team did a population-based case control study using the extensive informatic EHR resources at Mayo. They identified 1,250 people who were chart-validated first-time symptomatic kidney stone farmers, and then created a control cohort of 4,000 age and sex-matched people. And they found, consistent with previous studies, that the risk of kidney stones was transiently higher during the first year after antibiotic use. However, when they did careful adjustment for comorbidities and exclude subjects with prior urinary symptoms, they found there was no longer a risk associated with antibiotic use. The findings were consistent across antibiotic classes and the number of antibiotic courses received. This study allowed the conclusion that antibiotics are not, in fact, an important risk factor for kidney stones. The apparent causality arises because stones initially may cause urinary symptoms and be unrecognized and result in antibiotic use before a formal diagnosis of kidney stone. This is what we call reverse causality and is a common reason for an association. So an important practical paper that allows quite confident recommendations that antibiotic use per se is not, to the relevant patients, antibiotic use is not going to increase your risk of a stone. Finally, I want to briefly mention a paper that's also one of our highlights this month. It is entitled Loss of the Secretin Receptor Impairs Renal Bicarbonate Excretion and Aggravates Metabolic Alkalosis in Mice During Acute Base Loading. Jen Leipziger and his co-authors have developed a very compelling story that indicates that blood alkalinity increases secretin release from the small intestine, and that secretin acts as a bicarbonate regulating hormone. To the physiologists listening, I think this is an important kind of paper that will require textbook chapters to be rewritten. Secretin really seems to function as a hormone for acid-base regulation. So thank you all for listening. I hope you enjoy papers in this issue. We think it's a terrific issue and that there's lots there that should provide interesting reading. Again, thank you for your attention.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.